were not sick. A child came with hypertension, sweating, priapism, shock. He also foundation was. Those were not sick. Senior life.
Good evening, friends. We welcome you all for the broadcast of the PG clinics under the aegis of the Presidential Action Plan 2014. This activity is brought to you with a generous grant from Alembic, the makers of Azithral, and we are really grateful to them. We begin today's session straight away. Dr. Ramya will be presenting, and our guest faculty today is Dr. Vrajesh Udani, who to any pediatrician in India action. Come, Ramya.
Good evening, everyone. My patient R.V. Jain, 1.5-year-old, female child, first by birth order, born of non-consanguineous marriage, Jain by community, Hindu by religion, residing at Dharavi, hailing from Rajasthan, brought by parents with delayed attainment of milestones. There's a significant birth history, so I would like to start the birth history.
Not a good idea. You always talk about the chief complaint first.
Chief complaints of delayed attainment of milestones. I would like to start with the developmental history. Child attained gross motor. Child attained head control at 1 year of age. Rollover at 1 year 2 months. At present, child cannot. Developmental IQ DQ is 27%. Fine motor, there is fisting of hand. She doesn't reach out for objects even now. Social milestone, social smile, she attained at 1 year. Language, cooing is present. Other than cooing, she doesn't do anything. According to parents, hearing is normal. She responds to any loud sound. Vision, she doesn't follow objects or doesn't follow anything.
What's her language development?
Cooing.
Receptive language. Cooing is expressive, right?
Yeah.
So what is receptive language?
When they try to pacify her, she gets pacified. Like.
Yeah, but what is the key milestone for receptive language? Earliest. Everything else is social, no? Looking, smiling. Anybody? Use the mic. Consolable to mama's
Consolable
voice.
to mother's voice.
Okay, but that's a little difficult. What is the milestone you ask for? Responding to name, correct. So when does that happen? Does she respond to name?
No.
So, what's the receptive language? I mean, what age do you think that happens? You respond to your name.
Raise your hands and ask for the mic.
So turning head to the when the name is called comes at around 4 to 5 months.
Correct. So the receptive language is below that, according to what you are saying.
Yes, sir.
Is there anything else you want to tell me about when did the parents come to know? When did they realize there is a problem?
At 3 months of age, when she was 3 months old.
Because of?
Because she was not looking at them, and
So there was.
they found her abnormal.
Okay. So she did not have eye contact.
Yeah.
Okay. You think that's important? When they came to know? Why? Anybody?
That
Okay. What do you mean by onset of the illness?
To know whether this particular problem has been there since birth, or to know whether something else happened later which caused the delay. To know that.
Important, there's developmental delay. Suppose you see a child at 1 year and he's not walking, but suppose the head control was at 3-4 months, and suppose sitting was about 8 months, and about 15 months there is no walking. What would your assessment be? What would you call that?
Regression.
Let her answer.
If at all he is able, matlab he is attained his.
At present is the current. We want to know when it started. So, I'm giving you the example. I was holding head by 3-4 months. By 8 months she was sitting without support. At 15 months she is not standing or she is not walking. What is your interpretation?
In case of, at times there can be early attainment of milestone like head control in a spastic cerebral palsy.
No. Okay, what is developmental arrest?
Early milestones have been attained and further the child is not able to attain after one particular
point. So you arrest
point.
at a particular time. So, for example, if you have a onset of a disease which is causing the delay, or say at 6 months, then you would have early milestones normal, then arrest. And arrest may improve a little later or may even deteriorate. So at that particular, so the very important differential diagnosis depends a lot on when your developmental delay was noticed and when your developmental delay was actually manifest. So in this case, of course, what you are saying is that she was not having or he was not having eye contact at 3 months and therefore they noticed. So very likely that means delay from
Birth.
Correct. And this is important because you are dealing with this, your basic developmental delays and other developmental issues. You basically want to know whether it's a static process, whether it's a progressive process, and what is actually causing it. And the differential diagnosis really rests on that. Okay. So you said the developmental motor was what?
Yeah.
Very exact. Okay.
Fine motor and social 16% and language 20%.
What you are saying is that, okay, go on. So what would you classify that as?
Global developmental delay with visual impairment.
Visual impairment. Could it be anything else? Could it be...
Cortical...
No. Visual impairment means what?
Not able to...
What are you
Some
implying when you
difficulty
say
in-
there's a visual impairment? And let me put you the other word. What is visual inattention?
She's not able to perceive even light or anything that will be visual inattention.
Visual impairment means, anybody can tell me? So very simple. You're implying a lesion. Sorry.
Visual impairment would be there is no perception or there is decreased perception of light, whereas visual
Of light, no.
means
Light is not the only thing you see.
Of whatever is there in front,
Okay.
and visual inattention would be the vision is normal, but they
Correct.
don't want to that.
So how do you tell the difference?
Pupillary-
Let's come that when we have the examination. Okay, go on. So you're not sure it's visual inattention or visual impairment?
So there is no perception of light.
Okay. And you come to that conclusion from the examination.
Yeah, but even parents are like, whatever we do, she doesn't like taking object close to her eyes, switching off or on the light. There
She
is
doesn't
no.
look. Okay.
I'd start with birth history. Mother was antenatally registered and immunized with tetanus toxoid, 2 injections. Ultrasonography was done at 3rd, 7th and 9th month. Quickening appreciated at 5th month. There was no fever or rash, no headache or radiation exposure, no history of hypertension or diabetes. It was a full-term vaginal delivery, meconium stained liquor. Baby cried immediately after birth. Birth weight was 2.5 kgs. Child was breastfed after 1 hour. According to mother, for first 2 days, child was accepting as well. On second day, although mother noticed that there was history of excessive crying, followed by on the third day, there was history of convulsion in the form of staring looks, for which child was shifted to NICU. And child.
What is convulsion? What is the meaning of convulsion?
Convulsion is due to.
It's a seizure, right?
Both are different.
Yeah, so tell me. Seizure, what is this convulsion, and how do you make the difference? Is there a difference?
Convulsion is what we clinically or the symptom complained by the.
You said that she was staring. So is there a convulsion?
It's a seizure.
So convulsion is a motor management.
Correct. So motor seizures are convulsive seizures. All convulsions are seizures, not necessarily, but most convulsions are seizures, and other types of seizures are not called convulsive. They can be called non-convulsive, or you can call them, complex partial or whatever it is. So when you say staring, you are not saying it's not convulsive. This is important semantics. Most people don't use the word convulsions anymore. Because seizures, what is seizures? How do you define them?
Electrical discharge.
How can you define that now? Oh my God, this is very difficult.
Signs and symptoms occur due to synchronous neuronal activity of the brain. It's called.
That's fine, but what is a seizure? A seizure is a clinical change. It's a clinical change which occurs because of all that electrical activity, etc., etc. So when you see an episode, or you only even call it convulsion in the beginning, unless it's obvious motor seizures, we just say that it was an event or a paroxysmal event which happened suddenly and went off suddenly, and it consisted of staring. Later on you justify whether it's a seizure. No, I'm talking of this particular case, I'm just talking in general. It's a seizure, or the other events which can look like seizures, what are called seizure mimics. Correct? So you must not close your mind just because something happens, it's a seizure. That is the usual sort of knee-jerk conclusion which most people reach. In this case, what would you describe this? What kind of event was this? What kind of seizure was this? No, I'm not talking about, you said she was staring. So, was it epilepsy or was it, what do you think?
It was
It was epilepsy.
No.
It wasn't epilepsy. Okay. Can you get epilepsy at birth? What is epilepsy? So these are clarify your thoughts on this. These are very important things in the future, not particular this particular case. So when you have a seizure in the period, is it usually epilepsy or is it something else?
Something else.
What?
It can be metabolic.
So what is it called?
Sir, it's called acute symptomatic seizure.
Correct. Acute symptomatic seizures. 90% of newborns have acute symptomatic seizures, and the ones who and 10% are actually epilepsy. So what is the difference between epilepsy and acute symptomatic seizures?
After correcting this acute symptomatic seizure, they might need not recur.
You may not be able to correct everything. What is the meaning of acute symptomatic seizures versus epilepsy?
Either two episodes of seizure after 24 hours apart, or only one episode associated with abnormal MRI or abnormal
Suppose
EEG
this
finding.
kid had seizures on day 3 and seizures on day 4 and seizures on day 5. Would it be epilepsy?
If associated with abnormal MRI, even after first episode, we can say it epilepsy, sir.
I'm asking you the difference between acute symptomatic. I mean, conceptually, how do you look at these two things?
Already an abnormal brain.
In epilepsy, electrical activity on even get it. So.
No.
There is in epilepsy is usually syndromic.
No.
There is no provocation which is there in case of
Absolutely,
epilepsy.
that is provoked, unprovoked. Provoked, any of us can get a seizure. Okay, you get hypoglycemia, you get asphyxia, you get a seizure, you get brain, I won't say brain tumor, but you get a brain stroke. But epilepsy means what? There's a change in the epileptic, there's a change in the electrical circuitry, the neuronal circuitry, which makes the brain more liable to throw unprovoked seizures. Now that usually manifests as recurrent seizures and all these things about recurrent seizures 24 hours apart. Because when you have a patient who comes, not this particular patient, but any other patient who comes with the first seizure, you don't know whether it's acute symptomatic or it's epilepsy. Correct? If he's, you may not be sure at that time. So you make sure that you say epilepsy means definitely there's a change in the circuitry, and that is manifested by electric on the EEG. But you don't make those decisions waiting for the EEG. You make a decision on the clinical. Okay? So epilepsy means you are actually having a predisposition to seizures, and that takes time to develop. Therefore, most neonates, which is the very time when the brain can seize due to almost anything, seizures. Okay, then?
Child was shifted to NICU, required mechanical ventilation.
One minute before, what is the clinical evidence that this is acute symptomatic seizures? From your history.
First 2 days, child was well accepting feed. There was nothing. And on the third day,
certain epilepsy which can come on the third day. Epileptic encephalopathy of infancy, whatever.
So, history of meconium stained amniotic fluid suggests that there was intrapartum asphyxia.
No, before that, after that. So something you said.
The baby was irritable.
Irritability. So what is the meaning of irritability? Excessive crying, irritability. Feeding was there or not?
after that child reduced feeding.
Reduced feeding. So poor feeding, irritability means what? What do you call that? Neonatal encephalopathy. So when you have an encephalopathy, when you have an associated, so there's feeding problems, there's drowsiness, there's irritability, whatever it is, that means there's something gone wrong with the brain, and that's why you're seizing. So the most likely it's a provoked seizure, because most things in the newborn period, asphyxia, hypoglycemia, all these things usually give rise to an encephalopathy initially and then seizures. So seizures is part of the encephalopathy. Suppose you had told me that he had a seizure on day 3 and he was feeding fine and suddenly had a seizure, and then after the seizure was over, 2 hours later he was feeding again, that means there is no encephalopathy. Okay? So let me ask somebody else, because I am sure she knows the answer. What? This is at day 3.
Yes.
So day 3, day 1 is what cause?
HIV.
Those of you who want to answer, please raise your hands. We'll pass the mic to you.
Okay. And day 2, 3? Most common cause?
Sir.
Metabolic means what? Which one?
Electrolyte imbalances or hypoglycemia.
Most common? Hypoglycemia. Correct?
Hypoglycemia. Then hypocalcemia can also.
hypocalcemia, when does it occur usually? There's one early onset and one that's late onset.
After day 3.
Most early hypocalcemia is a what? Part of some asphyxia or something. And late onset hypocalcemia is usually because of top feeding. You know, you're not giving the right calcium, phosphorus, you're getting deficient in D. So comes in 3, 4, 5, 6 weeks. So usually what is the cardinal sign of hypocalcemia? Little encephalopathy or no encephalopathy. So in this case there was a clear encephalopathy after which the seizure started. So it's definitely, probably not hypocalcemia. And then later on you can get, end of the first week you can get any other important causes? Infection, meningitis, absolutely. Okay. These are all acute causes. They cause a symptomatic seizure.
Child also had icterus for which phototherapy was given for 2 days, after which the icterus resolved. Child was started on nasogastric tube feeding on 6th day and was discharged on 18th day of life. On discharge, child was accepting breastfeed and was put on anti-epileptic, some medication for next 3 months.
What is the birth weight?
2.5.
Is that normal?
Yeah.
Okay, fine.
Presently, after that one episode of seizure, child had no more such till date. There is history of scissoring of legs since 5 months of age, and there is stiffness of the body noticed by the parents. There is no history of any abnormal movements, no history of recurrent respiratory infection, no history of any pressure.
Why do you ask for respiratory infection?
Because of immobilization. One is that, and there is aspiration pneumonia or feeding difficulties which will cause.
So why do you tell me there is feeding difficulties? How do you tell about feeding difficulty?
There is regurgitation.
No, what is the usual? Why don't you answer?
Sir, in this case, baby may require a long time to feed, or may suggest that there is a feeding difficulty, or
long time, yes, but
or regurgitation, recurrent regurgitation due to pseudobulbar palsy due to diffuse cerebral event.
No, I'm not denying that you have more chance of reflux, but reflux occurs in so many normal infants also.
Sir, that is because of oromotor dysfunction in this baby, because of involvement of...
How do you diagnose feeding difficulty from the history?
This is not.
One is recurrent respiratory infections.
Is not able to suck and proper swallowing.
Sir, weight gain of the baby.
Not taking direct breastfeeding.
Okay, so sucking issues, fine, but many of them suck and they have problems in swallowing. Correct? So how do you tell swallowing? Drooling, okay. And number 2?
Sir, sudden choking episode.
Choking during feeds. Coughing during feeds. And typically these kids, many of them who have significant feeding difficulty, don't like to feed. Every time a feeding is a pleasurable thing in most infants. It's not many of these, where you have problems in swallowing, because it's like every time you drink your milk, you feel like you're drowning. So obviously it cannot be very pleasurable. And therefore they start crying as soon as this is started and all this kind of. So one of the questions you should ask is, does he enjoy feeding?
Yes, in this child.
He does?
Yeah.
He does. So then there is no significant feeding difficulty. At least, but not significant. He doesn't choke.
No.
Very good.
Immunization. Immunize.
No, but that's
1.5 years.
okay.
Child is immunized till booster 1 as per universal immunization program. Diet history, she was exclusively breastfed till 6 to 7 months. Then there is calorie deficit of 400 kilocalories and protein.
What kind of vaccination would you like to give this patient?
Things like pneumovac. Then,
because they are more. Hip is not special, is it?
UIP, it's not. They belong to lower middle class as per modified Kupuswamy classification. Call the class. Shall I call the class?
Sure. The end of the story, just summarize the history in brief and tell me what you think has happened. So when you end the history, you must have a working diagnosis. You must have an idea of where the problem is and what the problem is and maybe why the problem is. These are the three things in neurology you always know. So from your history, the majority of patients in neurology, your history gives the diagnosis and your examination probably confirms it. So just tell me in summary what your
1.5 year female child with
please say baby girl.
1.5-year-old baby with static encephalopathy with global
just summarize the history.
With history of delayed attainment of milestones. With significant birth history.
We had this thing called Précis writing.
So use adjectives to convey a lot of stuff. So you said delayed milestones. Now put one word before that, delayed.
Global.
And significant. So now that tells you that, that puts everything in context. From when?
Since birth.
So put that way, no? He is saying Précis writing.
So 1.5-year-old girl had with severe global delay, with visual inattention stroke impairment, and with a significant encephalopathy on day 2 or 3. Correct?
And what else is there? Your antenatal is apparently clear. So with
normal antenatal period. And the is normal. That means that something has happened, not, it's in the perinatal period, but it's after birth. Okay.
So now what is your impression? This is your summary. Now what is your impression?
It can be a static encephalopathy like cerebral palsy.
Static encephalopathy like cerebral palsy.
It is a static encephalopathy.
Okay. And how have you come to the conclusion it's static? Maybe he's got an early onset metabolic disorder and he's got, paroxysomal disorder which starts very early in life and he's delayed. He's not regressing. So is there anything you've asked?
Family history.
Benji, धीरे धीरे फायदा हो रहा है, थोड़ा बहुत हो रहा है, यानी कि 6 महीने पहले जो कर रहे थे अभी और भी कुछ कर रही है? क्या कर रही है?
यह है ना, मतलब कसरत से थोड़ा फायदा हुआ है. मतलब ये हाथ पैर भी हिलाती है, गर्दन भी उठाती है और हूँ भी करती है, स्माइल भी.
वो पहले नहीं कर रही थी?
नहीं.
आपको देख के स्माइल करती है अभी?
हाँ डॉक्टर, हाँ हल्का.
पहले नहीं करती थी?
नहीं.
अच्छा, आपके आँख से आँख मिलाती है?
नहीं डॉक्टर.
So she is improving. That's how you come to the conclusion that it's probably a static encephalopathy. What do you mean by cerebral palsy?
Cerebral palsy is the same, that is static encephalopathy, which improves over time, as like this case.
गड़बड़ हो गया यार. Anybody can correct him?
It's a disorder of movement and posture causing...
Movement and posture. You may not have any mental retardation or cognitive or social or anything. It may be as mild as a kid who just has toe walking and has got a mild spastic, to someone who's got cerebral spastic quadriplegia, mental retardation. So please remember that it is a motor and movement and posture problem. Many people say MRCP. That's only a degree. You have to be very clear when you think, so that's, so this is obviously affecting more than just motor. He may be having cerebral palsy along with other things. But the syndrome is global developmental delay, and the only point for cerebral palsy which is mentioned is scissoring. Because what does scissoring mean?
Increased.
Where?
In the lower limbs, adductors.
So adductors and sometimes the medial hamstrings and all that, they become spastic and you get scissoring. Okay, let's examine.
Can we have one or two volunteers also to come around quickly? One or two people to...
What is the first thing wrong she did? Perfect. Baby should be in mother's lap. She has assumed the baby will not cry. She did. So the first thing is, neurological examination in infants is not the standard way. Please don't talk about cranial nerves, I couldn't taste the smell and all that. Okay. You have to examine the baby in the mother's lap so that she is comfortable. Now this one is obviously significantly delayed, doesn't recognize the mother as such. So it may not be a problem. But otherwise you must examine the mother's lap. Can we bring him over here? चेयर लेके आना. आप एक काम करेंगे, आगे आएंगे. Can you get one more chair because I also need to sit. Better. टर्न करो ना.
Child is lying comfortably in mother's lap with extended neck, both the upper limbs flexed and both the lower limbs flexed. Vitals are stable, and anthropometry wise she falls in severe acute malnutrition with anthropometry wise she falls into severe acute malnutrition with microcephaly.
Okay, what's the head circumference?
37.5.
What's the head circumference at birth?
33 to 35.
So what is your inference?
You asked her head circumference at birth.
No, I'm asking you. You said 33, now it's 37, na? Now it's 37, so what is your inference?
There is impaired growth of the brain.
No, that's fine. But suppose she was 30 at birth.
Primary or secondary.
So what you're worried about is obviously something happened at birth which has hampered brain growth. No? Yeah. It's important to the head circumference, and this is to all pediatricians whenever they come to you for office checkup. Height and weight is usually done. Weight is usually done. Most people forget the head size. And this is, I'm talking from experience. You know, almost never find the head circumference written down anyway. And this thing about what is called acquired microcephaly, it changes the differential diagnosis. Okay.
General examination. Their head size.
There are so many other things you can talk on inspection. No? So first, talk of we've done so many times in neurology. Don't get tensed. With Dr. Udani, even we would do as badly or whatever as
nobody's
good.
Going to do
So don't get tense.
Turn करो ना बेंजी. She gets a little uncomfortable. ऐसा रख सकते हैं?
Why don't somebody come, Amdekar sir, ask some exam going students, one or two, come along and
so what do you see on inspection, as Rajesh said?
Head size is.
Head size is small. Fine.
Yes. On examination, the child looks awake, but not is quietly sitting on mother's lap. Then on from head to toe examination.
No. What do you see on inspection? Head to toe exam बाद में कर भी तो वो तो touch करना पड़ेगा ना head to toe. On inspection alone, what do you see?
There is scissoring of the lower limbs.
Okay, so there is scissoring of the lower limbs. Fine.
Yeah.
Upper limbs are flexed. Left hand is fisted.
Okay, there is fisting of the left hand.
Cortical thumb is present.
Okay. One person speak then. She's very uncomfortable, unfortunately.
There is no facial dysmorphism.
Okay.
The child doesn't seem to be interested in the surroundings and is very irritable, but intermittently consolable by the mother.
When you say interested in the surroundings, she's not aware.
Not aware.
Of what's happening around her. She's not aware of new people, different people. 1.5-year-old would be obviously very anxious, would be clinging to his mother. That has not happened. Okay. What else do you see? When she cries, what happens to her?
There's some.
So she becomes stiffer. Correct? Her legs become more, the scissor more. She has a little bit of a ATNR coming up on the left side. She has
partially extended.
What is this called? Retrocollis, which means what?
Increased spasms of the extensor, neck extensor.
Spasms?
Increased tone of the extensor.
Which is due to?
Gastroesophageal reflux.
No, gastroesophageal reflux अभी हो रहा है उसको. Dystonia, nuchal dystonia. Okay? So, is there any other evidence of dystonia?
So
the hand she goes like this. So she's got dystonia. Anywhere else dystonia? अच्छा एक काम करो, ऐसे रख दो, उसको अनकंफर्टेबल होती है. हाँ, बल्कि मुंह दिखा दो. हाँ. The other thing you see is when she's quiet, you have to see that when she moves or whatever,
oromotor.
What happens? Oromotor. What does it mean? What are these called? What is dystonia? Can you please explain? Not automatism. Not automatism.
Abnormal posturing of the.
Oh, it may be sustained, it may not be sustained.
Variability in the tone.
What is the most important thing?
Variable tone.
Contraction of the agonist.
Twisting. So, all this agonist, antagonist and all that, वो सब theory है. When you see twisting movements, which increase on
stimulation,
which increase on action, and which tend to
be sustained,
overflow. This is a little difficult. taking anything. But suppose you have a child who is not much more functional than this, and he tries to do this. So his hand is moving like this, twisting, and his mouth is opening. If I want to take something, my mouth doesn't open. So there is no overflow to other segments. And that's important. Okay? And dystonia is typically any movement or certain movements more than others.
Certain.
Like for example, neck.
Extensor.
Yeah, so neck extension is much more common than flexion. Then wrist. Flexion is more common than extension.
Pronation.
Pronation is more common than supination. Dorsiflexion of the foot is more common than plantar flexion is more common than dorsiflexion. So all these certain movements tend to be more expressed in dystonia. Okay.
Has it anything to do with gravity, anti-gravity muscles or no?
No. Dystonia is problems of patterned movements. So typically, if you see an older child, say I'll give you an example of a patient dystonia caused by primary dystonia. They may have tremendous amount of dystonia when they're walking forward, but if you make them walk backward, the dystonia disappears. But that is because there's a pattern in your brain which has been formed for walking. Walking forward. Nobody usually walks backward. And that movements show more dystonia than those movements which are not practiced. So one of the ways, sometimes dystonic gaits can be very difficult to tell. They're very bizarre gaits. You make them walk backwards, they walk perfectly, or at least very much better. So that is the pattern movements, and these are basically dystonia. Okay.
You can talk a lot about cranial nerves also on inspection.
Yeah, so please tell us. What are the cranial nerves? She's gone to sleep.
The second cranial nerve for the acuity,
Please show me how you check her vision. In a baby, how do you check vision?
So for her or just for a normal infant, in her, since we are on the history, we have a history of either visual inattention or visual impairment. We would first do the menace reflex.
Test it. Menace reflex. No, she's too below normal to do menace reflex. उसको समझेगा नहीं कि तुम मारने वाली है. हवा भी गया तो eyes can this thing. So that menace reflex is not something which you use.
We can do perception of light and
no.
Bring face close to.
That is the thing. I have to show you. Unfortunately. Hello. She's not really stranger anxious. She's gone to sleep now. But you make funny faces. See that? She's dystonic. She's becoming severe. No. Unfortunately, she's sleepy. But basically, there are two things you can do. One is, the patient has to be awake, obviously, fully awake, and not crying. You use your face. You go as close as possible. You make funny faces. You make everybody else say, what a funny doctor this guy is. That's what you do. And the second thing you do is, you can use movement. In severely impaired patients, you use movement. Sometimes they follow the movement. Or you can use a red toy. That's the only thing which you should not use light unless the patient is completed and you want to just see visual blink. But big gap between normal vision and blindness. So light, but no perception of light is a really very severe form. Whether there is any impairment or not. Anything else in the examination which unfortunately we can't see it in her, but anything which can help you in deciding. Can you give me a pillow, please? Can you tell me how you would examination tell you about whether there is visual impairment or inattention? Not in this patient, she's very sleepy. Anybody? What are searching eye movements? No, searching, roving eye movements. So eye movements just move like this. That usually means severe visual loss. So they just search, they rove. Second thing is nystagmoid jerks. It doesn't have to be nystagmus. You may have nystagmus or you may have nystagmoid jerks, which are basically because of lack of sensory information from the visual area. So that can tell you. So if you have nystagmus, nystagmoid jerks, if you have searching eye movements, those are more likely to be visual impairment. If you do those things, then it is more likely to be visual inattention or
cortical blindness.
Posterior visual impairment. So anterior visual impairment, the anterior visual pathway, posterior, so nerves, the ocular, the globe itself, cataracts and all that, the optic nerves, the chiasm, all this is anterior. So if you have a problem over there, generally you have these roving eye movements, if it is severe, but if it is not very severe, nystagmus, nystagmoid jerks. Posterior on the other hand, and pupillary abnormalities. You may have pupillary abnormalities if it is front. Back, posterior, you do not have much of this searching and all this kind of thing. So it's very difficult to tell sometimes visual inattention from cortical visual loss.
Sir, if it is anterior abnormality, pupillary reflex will be...
Not always, but yes, it may be generally more abnormal when the optic nerve is involved. But,
This child pupils are reacting to light.
Correct. So it could be posterior, I don't know. Then what is the fundus? Fundus, it's by
fundus optic atrophy.
Okay, then optic atrophy, fine. So we'll talk about that a little later. Then what else? You can look at the eye movements. Unfortunately, we cannot demonstrate on her, but just looking at her up and down and all that, you can check eye movements. When she check the facial movements, you can see how the eyes close. What else did I notice when she was crying?
Gurgling sounds.
No gurgling sounds. आवाज नहीं आता है ना, गरगर गरगर आवाज तो नहीं आता है, और दूध है बिल्कुल नहीं पीती है बराबर. So see, there is no apparent pseudobulbar palsy or significant dysphagia. Her voice also was nice and loud when she was crying.
How will you distinguish between bulbar and pseudobulbar? Will there be lot?
Let them answer. How will you distinguish between bulbar? First of all, what is bulbar and what is pseudobulbar? Anybody else wants to answer besides these two? Somebody else?
Pseudobulbar palsy is a upper motor neuron palsy.
Of what?
Of lower cranial nerves.
Okay, of the bulb.
Bulb.
So bulb is basically medulla.
Medulla.
So the lower cranial nerve, the upper motor neuron, and pseudobulbar is that, and bulbar is the lower motor neuron.
Lower motor neuron lesion.
So tell me, how do you differentiate?
Sir, bulbar palsy would have nasal regurgitation while feeding, and there will be a nasal twang to the voice if the baby is crying. But pseudobulbar palsy.
Yeah.
Pseudobulbar palsy usually.
But suppose you don't have nasal regurgitation and nasal twang, does that mean this bulbar palsy is out?
Pooling of secretions in the oral cavity suggests element type of lesion.
Jaw jerk will be exaggerated in pseudobulbar palsy.
So all reflexes are exaggerated in all upper motor neuron. So which is the most important reflex which people check and then say?
Jaw jerk.
No, jaw jerk. Gag reflex. So if you have a gag reflex or if you have parietal movement, when you make a child say ah, and there is movement or there is no movement at all, and you do a whistling and there is no movement, that is more likely to be lower motor neuron, right? In a pseudobulbar you get exaggerated reflexes. In jaw jerk also brisk and other things are there.
Sir, in lower motor neuron there will be the low volume of the voice. Dysphonia.
Correct. Dysphonia, but all depends on which, is it all the nerves which are involved or not? So for example, if you have a glossopharyngeal, you might have nasal regurgitation, that particular area. But if you have, so dysphonia again is more common in lower motor neuron.
Does pooling favor lower motor neurons?
Yes, it does. But,
Khare sir asked
It's very
whether
difficult
pooling favors lower motor neuron, and sir is answering.
It's difficult to be absolutely certain just based on pooling. What I would say, a key finding from the history are nasal regurgitation, more lower motor neuron, dysphonia, more lower motor neuron, those kind of things are more lower motor neuron, and upper motor neuron would be more of, because many spastic CPs, they also have a lot of pooling of secretions. So it's not really, I don't find that it as a differentiating factor. Okay. What about now you can put him over there and examine him. You haven't finished, have you? So उठाना पड़ेगा. Just show me the maneuvers you do in a small baby for motor examination. एक minute. She's anyway sleeping. You see of the posture. What is abnormal about the posture?
The lower limbs there is scissoring present in the lower
Correct.
limbs. And the neck is also...
No, what else is there?
Uh,
These legs are little lifted up.
Lifted up. So
Correct? So that usually means hamstrings are tight. What else do you see?
Thumb is uplifted.
The
You're seeing a cortical, striatal toe.
Striatal toe.
Correct? Is there. What else do you see on the arms? Normally you keep your hands like this. She's keeping it pronated. And the last thing is the neck.
Neck is also
Little extended. So all these things favor hypertonia. Okay, dystonia and spasticity. How many percentage of cerebral palsies have dystonia? Sorry.
50.
Study किया क्या Sion Hospital? All. So some degree of dystonia is there in almost all patients with cerebral palsy, except maybe the ones who are just mildly toe walking or something. So it's always a proportion. More dystonia, more. What is spasticity? Demonstrate spasticity over there. It's a little difficult because he's sleeping, but still. What is she doing wrong?
So it should be fast.
Correct. So are you finding anything? What are you finding? I'm not seeing any catch. Hold on. Where is the catch?
So child should be awake to tell about.
I'm not saying it. Right now you're not. Whether you're awake or not, I don't know. But right now there is no obvious spasticity. Correct? Hold on. What else can you do to demonstrate spasticity? Show me what you do, even if you don't find it in this patient. What would you do? Where else would you look? Muscles become spastic. I've done this 100 times. I'm also getting bored now. Huh? Correct? Adductors. Then second, hamstrings more, obviously more than. So whichever muscles are spastic are weaker or stronger? They are stronger. Very correct. So if the weaker muscles are not usually spastic, the stronger muscles are the ones which are spastic. So adductors, hamstrings, anything else up there? There are 4 muscles in the upper. Tibia is anterior. My God. Gastrosoleus, correct? The calf muscles are spastic. And the last thing is hip flexors. Correct? So hip flexors, hamstrings, adductors and plantar flexors. So now you can show me how you would test for spasticity in each. You do the popliteal angle in newborns, don't you? So how do you do that? You're looking at it as if some first time you're handling a leg. Huh? Come here this way. Hold on. So whenever you're doing this you keep straight. This is adductors. Flexors. This is the catch. This is the catch. I'm showing you the catch. Now I do it slowly, see what happens. So if I do it slowly, I can do it much more without the catch. So it's always velocity dependent. See? Catch. And this is what decides actually Botox injections. So what we call the fast movement, where the catch occurs, this angle is called the R1 angle. And then you do it slowly, and it's R2. Now if R1 is equal, what does that mean? Contracture. So it won't help Botox. But if R1 R2 difference is 30 degrees, you could use Botox. I'm not saying I would use Botox in her, but you could use. Okay. Similarly, if you're doing, hold this down. Keep this leg extended. Rapid. I'm showing you the catch. Correct? Now I'll do slowly. Straight. So R1, R2, big difference. Third thing is soleus. This leg, knee straight. Fast. Not much. I don't see any. So if I have to say, I say this patient has hamstring spasticity and adductor spasticity. Not much of gastrosoleus. Upper limbs? Which is the muscle which is usually more spastic? Okay, but more than that, earliest? Pronator. So what you do is, unfortunately he doesn't have it. Even this is not much. Then the pectorals. Okay?
Is there something like active tone and how to examine for that?
Active tone and passive. Basically, those are actually more physiotherapy words. What I usually use is what is tone and what happens when you try to do something. So dynamic increase in tone and tone when you are not moving.
I think some students were asked in exam tone and passive tone.
How do you examine for passive tone?
Passive tone is when the child is not moving at all. That's the time when the child is passive. And active is when the child is active and you see the tone at that time. I'm not sure what this particular terminology
offer resistance of the muscle that you see on movement. So you try to move and there is
so
a
basically it's
resistance
an action related tone change.
I just also wanted to draw your attention to when you are doing the maneuver, which Rajesh was doing, there was some prerequisite for that, and if you don't do that, you may get wrong results. For example, when he was showing the adductor catch, he had flexed both these legs. When he was showing you the knee, he made sure that the other limb was extended.
And the
when he
same
was
thing,
saying the ankle, he made sure that this was completely.
Knee was extended.
Now, if you don't follow this prerequisite, your method of examination is wrong. So please note, those may look minor, they are very important.
So other thing you can do for hip flexors, for example, one of the things is if you look at her, she's probably got a hip flexor because the hips are flexed. So hip flexors, which is iliopsoas femoris, are probably also hypertonic. If you want to see if they're significant, how do you do it? You turn her over and keep this and look, and you can see the pelvis is actually coming up. So there is a bit of hip flexor tightness as well. Okay. Just show me.
So we'll do the 180-degree flip test.
Karuna. Why you want to support the head?
She's sleeping now though. head will, the head
No,
lag.
you show us the maneuver. You don't have to show us in this particular patient.
In first I'll do pull to sit.
Okay. And what does this show?
There is head lag, and we'll have to look at the back if it is rounded or is it straight, and the traction response if the child is.
What is traction response?
The child will give some resistance to
No,
the
like this.
the flexion when we pull the child up.
So many hypotonic children also will be like this only. Like, there will be no sort of.
Then I'll do the axillary suspension. There is scissoring of the lower limbs.
And what else are you looking for?
For if the neck is extended.
Correct. So if it goes back, so you can see retrocol is much easier like this. And what else do you do in the shoulder?
Slipping through.
Whether to check for hypotonia, the baby will slip through the shoulder.
Is he slipping?
No.
So now he is sleeping. So he might slip. I can see him slipping. See, as soon as he wakes up, his tone increases. And he's slipping. What does that tell you?
Changing tone and.
So you have hypotonia in this and hypertonia in others. The most usual place where you get hypotonia is axial tone is very often reduced. And tone in the limbs is very often increased. So this is a hypotonic situation.
We can do the
now
ventral suspension.
What else do you do?
Ventral suspension and putting the child in the prone position.
Yeah, so show me. Now he's awake, so let's see. What do you expect? Don't drop him, huh?
Yes.
So his head is coming up.
And the head is coming up. In cases of hypotonia, there will be a ragdoll-like posture.
No, so in patients with dystonia or with cerebral palsy, you get this neck going upwards. So there is increased development in prone. So if you look at a prone, a child, head may be coming up like this. So it's like a 3-month-old. A pull to sit is much lower. So in supine, development is much less than prone. That's another way you do it. What else do you do?
Then in putting the child in the prone position,
Anything else you want to do?
Neonatal reflex. Primitive reflexes, ATNR and.
So what did you see just now?
Symmetric reflex.
You see that?
Yes.
So obviously not a complete morose. Complete morose will be like this. This is partial morose. What else is there?
ATNR.
So where is the ATNR abnormal?
After
ATNR is normal. Can it be normal?
It should disappear after 3 to 4 months.
Okay, so at 3 months I see ATNR. Can it be abnormal? You will say 3 months is normal.
It's abnormal if it persists after 6 months.
If it's obligate at any age. What is obligate? When he can't break it. The ATNR posture, the normal baby, he does it, then he breaks it. Then again he goes there, again he breaks it. Obligate means when he turns, he can't break it. He keeps the hand or leg or both extended. That's abnormal at any age. So for example, see that over here, leave it. He is not really having an obligate ATNR. First thing which happens is it becomes straight, but then he breaks it. Obviously in his case it is abnormal because it is going on till the age of 1.5 years. Okay. The reflexes are?
Brisk.
Okay. Is there clonus?
In sustained clonus is there.
I didn't see anything. Very few beats. Okay.
Is it mandatory that when you shake the reflexes, deep tendon reflex, the head should be in the midline?
Midline.
Otherwise, you make.
Yeah, that is for asymmetry. So when you're suspecting that there might be an asymmetry of reflexes, there's an asymmetry, the hemiparesis or something of that sort, or you want to see an asymmetry, then the head should be definitely in the midline. In this kind of situation, it doesn't make that much of a difference because he's, we're not expecting asymmetry. He's got bilateral stuff.
So should we do the parachute reflex also in all child?
What does it mean? It's very bad for the back.
Because I was asked the question, it was a 7-year-old spastic diplegia CP. And
can you imagine carrying him and doing, my God, my back is hurting thinking about it.
I was asked whether I tested for the parachute. Like we should be testing for parachute.
Parachute is important in what?
It is a postural reflex and it persists.
How does it help you?
It helps in, it's a balancing.
How does it help you in? How does it help you when you examine the patient? Forget about the exam. Exam is not the only thing. How does a parachute help you? When I do it sometimes, but I do it when the patient's mother asks me, is this child going to walk? Before you walk or before you stand, you have to have the parachute. If you don't have the parachute, no matter how much physiotherapy you will do, you'll never walk. Correct? So that's a very important reflex in that. And I usually make my residents do it so I don't hurt my back. But that's important because that's an important. Otherwise, there are many reflexes. There is neck to body writing reflex. There is a grand reflex. वो करते जाओगे तो कभी खत्म ही नहीं होगा. Okay? So your basic idea, at the end of the exam, she wants to know certain things. Okay, before we go to that.
Doubt I had. In her developmental ages.
Sir, can I ask a question from this? They want to know whether ankle clonus has to be tested with the knee in flexion or extension.
Always flexion.
Always flexion.
Sir, in this patient.
And you may have to do it in different positions. Because babies, are not going to be very cooperative. So if they move the leg, you might miss it. Do it when the baby is relaxed, you do it that way.
Sir, parachute reflex will be attained irrespective of their developmental age or
Don't develop the parachute, no? Don't walk. Don't develop the parachute. So if he doesn't develop the parachute, he can't walk. That's what I'm saying. It's a reflex you have. There are many protective reflexes. Is one, propping is the other. So if you do not have propping, I'll show you. This is the ATNR. Okay? Now I do this. And I do this. He doesn't put his hand down. Okay? That's lateral propping. Without lateral propping, you can't sit. So these reflexes have to be there. And no therapist can bring it on. If it's going to come, it's going to come. If it's not going to come, bad luck.
So I think means what she was asking, that parachute will come irrespective of development. No, in fact, normal parachute comes at about.
So her age is 3 to 4 months. So
no, exactly. So what you're saying is that she may become, older and she may still not develop the parachute. So it's not that irrespectively it will come. No. Okay, लेके जाएंगे. I mean, you could do it, but tell me. So what do you think? So after you've finished examining, what is your impression? Can you summarize now the whole thing? Physical, and this come to a conclusion?
1.5-year-old baby girl with of severe global developmental delay with visual impairment or inattention with significant perinatal asphyxia. Without neonatal encephalopathy. With neonatal encephalopathy.
Examine the child, na? So you add something before you come to the etiology.
With spastic quadriplegia.
That's all you want?
Mixed.
So mixed spastic, dystonic and sometimes hypotonic quadriplegia. Okay.
Without any... Due to neonatal encephalopathy.
Neonatal encephalopathy is caused by something. So you said perinatal asphyxia.
It can be hypoglycemia. It can be due to hypoglycemia.
No. What do you think it is?
Sepsis and there was icterus also for 2 days. So should we take that?
Okay, so what you are saying is there were multiple risk factors and you can say perinatal brain injury rather than specify what it is. What is the problem with perinatal asphyxia? From the history.
She had sepsis,
The child was normal for the first 2 days. So
correct. So usually perinatal asphyxia does not occur after the first 2 days unless the baby or something happens, something else. Otherwise, perinatal asphyxia is an event which occurs at the time of birth or sometimes may occur intrauterine. So you may have a patient who has intrauterine asphyxia, recovers from the asphyxia, has meconium staining because of that and comes out usually encephalopathic. So he comes out, he's not feeding, he's not crying very well, stuff like that. But according to your history at least, the first 2 days he was fine.
So but the meconium, the liquor was meconium stained.
Yeah, I'm not denying it. I'm just saying that very often you may not be able to come to a definitive thing whether, and therefore you call them risk factors. So what are the risk factors of perinatal brain injury? In her case, meconium stained liquor, neonatal encephalopathy. She said jaundice, hyperbilirubinemia, but I'm not sure you said it was severe or anything of that sort. So I don't think that was the case. Low birth weight, no. I have a problem with calling, this is 2.5, but suppose he was 2.4 or 2.5. The question of low birth weight is always what is the expected weight in that particular child? What is the destined weight in that child? So if you classify birth weight as below 2.5 kilos, many people in India call it below 2 kilos. But the problem is that is really not relevant in a particular case because that case may, what does low birth weight tell you? There is intrauterine malnutrition. So intrauterine malnutrition, if suppose a baby was supposed to be 3.5 the way he was growing and then he comes out 2.5, he's considered normal but he's not really normal.
I think if it's a second baby, it may be a good idea to ask what was the first baby like.
Correct.
If the first baby was 3.5 and this is 2.5, then I think it's a low birth weight.
Okay. So the problem with perinatal asphyxia is that. You said what is the problem with hypoglycemia?
Sir, if we have to correlate now, she has visual impairment and there is...
So fine. So in babies with hypoglycemia, what are the cardinal features? Hypoglycemic, where does the injury occur?
Occipital lobe.
So posterior. So visual inattention. But if it occurs posterior, what should not be there? Where do you think this baby's lesions are? Where do you think this baby has problems? You said, okay, in the optic pathway she has lesions. That's why he posterior optic pathway. That's why second?
Putamen or basal ganglia?
Basal ganglia. motor cortex, basal ganglia, white matter, all these are usual in hypoglycemia. So usually you have posterior, so you can't see, and very often you get spasms, and very often the epilepsy is very common because posterior areas seize much more often. Later, I'm not talking of the neonatal seizure, I'm talking about later on, the epilepsy which develops in these babies. So this kind of thing, if you see a spastic, dystonic, quadriplegic, microcephalic, visually impaired child, what are the likely things? What affects the basal ganglia, the motor cortex, the white matter? Asphyxia. Absolutely correct. Kernicterus. But kernicterus, what is the point against?
Not severe jaundice.
No. Forget about the history. Maybe they didn't realize. How the hell would you know? She's not. Correct. They are socially good kids. I always tell this story. I was in the US training, and there was a 16-year-old boy who was lying in the bed, and we were taking rounds. And I was a resident, and I said, yeah, he's having significant mental retardation. And suddenly there was a flurry, and that boy typed out. He could type, I am not mentally retarded. It taught me a lot. It taught me that you should not say anything in front of the patient because you don't know what they can understand. And that children who have lesions in the central grey matter, which is basal ganglia, etc., may be cognitively very good. They can't speak because of dystonia of the oromotor muscles, they can't coordinate, they can't speak. But they can understand a hell of a lot.
They won't have a seizure, usually.
In asphyxia, for example, you may, because in asphyxia, the central HIE, there are two types, no? What are the two types?
Central and peripheral.
Central and peripheral. So what are the differences? Tell me. Central is central grey matter and perirolandic cortex. And peripheral is entire cortex. So the peripheral is spastic quad and severely retarded, like this kid. Well, a central one has got severe dystonia, but is socially active, obviously we can't test the IQ, but much better socially. So I think these things are important for prognosis, that's about it. What do you tell the child about the parents have gone out?
They're waiting.
Outside? Not inside, no? So what would you tell them? मेरे बच्चे को क्या होने वाला है?
I will.
चलेगा?
I'll tell them that.
Before that, you want to investigate it? What?
I would like to do a neuroimaging.
Why?
To know the areas of.
How will it help the baby? So when would you do neuroimaging in a cerebral palsy? Fine. So what you thought was cerebral palsy is now worsening. Can cerebral palsy worsen? Why?
Sometimes patient develops a seizure.
Seizures, unless you have status or something, I'm saying worsening motor performance.
Due to spasticity, we think...
Contractures. So contractures, joint deformities, spastic dislocation of hip. Your physiotherapy is basically to prevent all these things. What does spasticity do? It shortens the muscle, it causes of hip, it causes deformities developing, it causes pain. And you may not think, pain, but the poor baby can be in significant pain later. So that's your physiotherapy basically is to that. Your physiotherapy cannot do what is not possible. It's not possible. But it can keep the joint supple, it can prevent the spastic dislocation. Therefore you got to, the first test X-ray of the hip joint. Absolutely correct. Because you want to know whether this kid has spastic dislocation or not. Imaging, when would you do? I would not do in this case. There's a clear history of neonatal encephalopathy. Why you want to waste his money? But if there is a history, no obvious encephalopathy, there is no, hyporeflexia instead of hyperreflexia. Head circumference is normal. There's consanguinity. There's a family history. All these things, maybe it is not CP. Maybe diagnosed as CP. Okay, there are many conditions which can look like CP. We won't talk about that now.
There are a lot of questions of people asking, because the child was, sensorium was normal for the first 2 days, could we think of IAM as an etiology, inborn error of metabolism?
You could, but the problem with IAM is that usually the neonatal IAMs are severe disorders. They have, most IAMs are because of enzyme deficiencies. So if your enzyme deficiency is severe, you present in the newborn period. MSUD, hyperammonemic disorders. So these kids do very badly. They don't improve. Very often they die if untreated. And if they don't die, they actually don't improve at all. No, this kid is definitely improving.
And I think the manifestations of an acute IM is often vomiting, lethargy and seizures.
But he had that. He had lethargy
but not
and
vomiting.
seizure.
It's a classical thing.
Correct.
And moment you put them on IV, they seem to recover for a while.
Yeah.
Because the insult has gone. So this child didn't behave like that at all.
Right. So I think there were no systemic symptoms as much as acid. We don't know that because you don't have all that history, right?
Sir,
but the point is, if you look at it 1.5 years, you don't have the birth history in detail. What you realized is that something happened. He became encephalopathic, and then he's never had an encephalopathy. He only said 6 months ago he was not smiling or whatever it is. Now he's doing that.
And would you also say that the IAM would come up a little later when more feeds went in or something like that?
Yes, you're right. Usually, but 3 days is okay.
Okay.
There are certain IEMs, for example, which can look very much like asphyxia. Even on MRI, for example, now, what is called a molybdenum cofactor or sulfide oxidase or whatever. But if there is a suspicion of that, consanguinity, family history, then I think it's worth doing imaging. Otherwise, if you have a clear cut like this, may not be.
There is an angle who's asking that in the exam, do I say X-ray hip as my first investigation, or what is the chronology, or what is the list that I should give?
This is not for,
I think the best way would be to say that while neuroimaging can be done, it's to help in this child. Your examiner might want a neuroimaging, but it's clear that it's not going to help me anyway.
Most likely. Yeah. Occasionally you can get fooled, I am not denying that. What you should do, investigative wise, in any patient of static encephalopathy is what? Document the deficits. So Bera, absolutely. OI, or whatever it is, yes. Usually you are checking, you don't do VEPs. You can do a fundus and all, that's fine. Just to exclude cataracts and other stuff. But you document the deficits. You want to know the etiology. If it is not obvious clinically, so then in that situation, MRI and all that. If there is epilepsy, you want to know what type of seizure, maybe you do an EEG, fine. But the more important is hip X-ray, more important is all that. And then of course, what do you tell the mother? Because one of the things which I have found, which is lacking in most pediatric neurologists also, is they don't tell them anything. Improve hoga. It's very difficult to tell. So what do you tell? Last question.
I would tell them that child.
मेरा बच्चा बैठेगा, चलेगा.
We will have to wait and see. You will have to continue physiotherapy and medicines for spasm.
So you are right. Initially, you don't tell them the whole truth, tell them half a truth. But you put it into the head that yes, I know and you know that this kid is never going to walk, never going to talk, is going to have a bedridden life, which is the truth. Them is, छोटा है, बैठना चाहिए. हमारा मकसद ये होना चाहिए कि ये बच्चा बैठे. चलने का तो बहुत दूर है. 2 साल तक बैठेगा तो गारंटी नहीं चलेगा. 4 साल तक नहीं बैठेगा तो प्रॉब्लम है. तो अभी 2-3 साल है, बराबर फिजियोथेरेपी करो, ये सब करो. नेक्स्ट टाइम शी कम्स आफ्टर 6 months के बच्चा कुछ नहीं कर रहा है. थोड़ा प्रॉब्लम तो है ज्यादा. ओवर अ पीरियड ऑफ टाइम this has to be made. And you want a gap of 2-3 years between patients. And the 3rd or 4th time they come to me. कितने बच्चे हैं आपके? ये मेरा पहला बच्चा है. उम्र क्या है? 27. दूसरा बच्चा करना चाहिए. एक तो नॉर्मल बच्चा होना चाहिए. Then the new baby comes and everything is. So remember one thing, you may not be able to cure this, but you can help the family cope with it. And this is something which is very important. Other medical things you should do, look for vitamin D deficiency. Almost all of them, 99% of CPs have vitamin D deficiency. You may want to do a PEG, dislocation of hip. All these things are things which happen in the cerebral palsy patient. And it may not be of good fun to the pediatrician. He's saying, kya bhai, nothing, it keeps boring me, kuch kar nahi sakta hai. But you have to help them. You are not just to cure, you are also to help. And that is the most important. So this kind of patient, you have to hold the mother's hand and you got to help the baby live as comfortable a life. It's a short life. He's going to be like this for a few years and then he'll get some intercurrent infection and pass. Okay?
There is a question whether is there a role of EEG even if there is no history of seizures?
Absolutely not, with clarifications. If there is a worsening cognitive or behavioral issue, I'm not talking of this child who has no cognition and no social, but I'm talking about less, and suddenly you realize the child is not doing well or whatever it is, or he was smiling at me, now he's 9 months, he stopped smiling and he stopped looking and all that. Definitely he may be having a subclinical epileptic encephalopathy. He may be having spasms. So I always ask them, because spasms are something which can be missed by the most observant parents. नींद के उठने के बाद, how do you tell spasms? Or somebody else has come. Tell me, no? How do you diagnose? You know what spasms are, right? So tell me, how would you diagnose spasms? Anybody? Waking up, cluster of jerks, either front, back, whatever. Sometimes crying. So you ask them, लचक तो क्या है? झटका मारता है क्या? चमकते है क्या? चमके जैसु. These are the different words you use in different languages. And if they're saying do the EEG for sure, because that patient will worsen in his mental development. Okay?
Sir, because this child shows improvement, we are not neurodegenerative at all. I'm just addressing one of the questions. Is that correct?
Yes. As far clinical is a certain point, you cannot be 100% sure on anything. Right. There are some atypical features. He looks like he had asphyxia, but the history doesn't suggest it and all that. But generally, babies do not appear to be neurodegenerative at all. Because the word degenerative starting at birth. It's too early. Very, most patients do not. There are some metabolic disorders which can start at birth and which can present with spastic, like I just told you, molybdenum cofactor, like 1 in a million cases you find that.
Right.
Parents are very anxious, they want to know, then do an MRI. I'm not saying you don't do it. So it all depends.
Yeah.
This child has got such spasticity. Now whether he has dislocation or no, it's not
painful. बच्चे को if it is dislocation without pain, okay, you don't operate. How do you know? If he dislocates, he might get pain. Then you are forced to operate. In a baby who is spastic, you have to put him in plaster. Goodness gracious. He's got osteoporosis. I had a patient who had a fracture after plaster. Because of the plaster, he was so osteopenic, the dislocation was 13 years of age, and he was in bed for he was in bed always, but he was in pain for 9 months after that. So it doesn't matter. You cannot cure the child. We are not here Jesus Christ. We are only helping people.
Right, sir. Our next case is presented by Dr. Shivani.
Can we be very short in the next case, or is it long case again?
Short.
Short. So what we'll do is you give the history, you go on the same thing, interrupt in the middle, but I'll try not to, and then you give the summary and your clinical impression.
A 4-year-old male child came second by birth order, born of non-consanguineous marriage, resident of Barala, brought by an informed
You don't have to be married to be consanguineous. So we always say non-consanguineous union.
Informed by father, came with complaint of not in his head since 2 days. Patient was apparently alright 2 days back when mother noticed that child was unable to hold his head and was keeping his neck in flex position. He was not able to move his neck sideways also. There was no associated pain or trauma of the neck region. The weakness was acute in onset and non-progressive.
How do you know it's weakness?
So he was not even able to move neck upwards or downwards anyway.
No, it may be restriction of neck movement. Why do you assume it's weakness? Okay.
So there was the head was actually a drop, like there's no seems like there was loss of tone.
It's all okay, but from the history you got that or from your examination? Examination. The two twain shall never meet. They only meet at the end.
Mother told that the child was not complaining of any pain or crying, and mother told that when he actually told him to move his neck up or anything, and he also noticed the child was playing, moving his neck at all.
Okay. Is there any questions you can ask which will help your does he hold up his neck?
Whether there was any pain associated.
He said no pain. She said it 3 times. No. Does he use his hand to look up like this? So if he's, maybe I'll do this. Can he lift up his head in the prone position?
No, from
from the history. Could he do that?
No, while he cannot get up from the bed, he cannot lift his head while.
Okay. Fine.
There was history suggestive of motor weakness in upper limb or lower limbs.
How did you find out that?
When in upper limb for distal weakness we
No, in this particular case.
He was able to feed himself. He can move his arm above the shoulder, and he can walk normally.
Okay.
And he can get up from sitting position.
So everything was fine. Okay.
There was no history suggestive of any cranial nerve involvement. There was no history suggestive of.
This is all the time.
Yeah.
Or this is sometimes worse than sometimes not so bad.
No, since 2 days he had that, and there was no other complaint except for this head drop.
Was he on that?
He was alright. Even before this episode, he was playing in front of mother. He was.
And how did this happen? Like this happened over time. All these things are very important. This is obviously a difficult case.
Sudden onset.
This is not something easy. So you have to tell me, was there?
No.
How did it start? How was it noticed by the mother? So when you have a problem case, you should know how the thing was noticed. Is the mom here?
Yeah. Yes.
Call her, no? Okay then.
No history of altered sensorium or seizure or anything. On inquiry, there was loose motions 4 days back. There were which was 4 to 5 times a day, watery, which subsided after 2 days. Between this illness and that episode, there was 2 days period of when child was absolutely normal.
Whenever you ask direct, you have first your onset, duration, progress, ODP. So you should tell us exactly how the symptom was noticed and all that, what has happened to it. Now 2 days is a short time, whether he's improved little bit, all that kind of thing. Correct? Second thing is, on direct questioning, direct questioning should be 2 things. One is to know the localization of the problem. And to know what other things may be involved. And then you come to the second part of the ODQ, etiology. So all that, please, you should tell me, no altered sensorium and all. Yes, but more important than that is? So any other muscles are involved or not? You said the lower limbs and upper limbs. What about the cranial muscles?
There's history suggestive of deviation of angle of mouth, or there's no histories of change in voice or dysarthria, drooling of saliva.
Remember, face is only if you have unilateral facial palsy. If you have bilateral facial palsy, you don't have deviation of face. And bilateral facial palsy is missed by the doctors also. Forget about the patient. So don't just say deviation, because it may be a bilateral problem. Did he have diplopia?
No.
You asked?
We can tell he cannot.
How old is he?
4 years.
बात करता है ना? Normal, ना? Why can't you tell you asked him?
Yeah.
No diplopia. Okay. Then? And no lower cranial nerves at all.
Since the time child is admitted in ward, weakness has improved a bit, but not completely.
कैसा है? Very good boy. The first thing, get friendly with him, then?
Since the time patient is admitted, the weakness is but not completely. Initially there was complete head lag, but not now. He is able to hold it for some time at least.
Okay.
There was no history of fever. There was no history of neck pain or trauma. There was no history of similar episode in past. There was no history of any similar illness in family, or there is no history of any outside food ingestion with vomiting, or there is no history of recent vaccination.
Okay.
Birth history is normal. Mother was registered immunized. It was a full-term normal vaginal delivery. There was no history suggestive of any perinatal insult. Child is immunized till date. He is developed.
I would say birth history is normal. Development is normal. He walked and he talked. When did he do that?
It was normal as per chronological age. Right.
So when did he walk? You didn't ask?
Because right now what he is doing.
Yes. ठीक है वो बिठाओ
वापस बैठ
वापस आ जाओ Okay. So milestones are normal. You walked and talked for 1 year or whatever that around that time. Okay. When you have a muscle case, which is a muscle neuromuscular case, what is the important thing you should ask?
Diurnal variation.
Fine, that she said. Not in this case so much, but was he running before?
Yeah.
पहले भागता था? चढ़ने में कोई तकलीफ नहीं, उतरने कुछ दिक्कत नहीं. ठीक है. Okay. You want to examine? Is there anything else in the history you have? So what is your, at the end, what is your, well, let's not ask you because you must be aware of the investigations. Let's ask somebody else. Who is appearing for DNB? That guy in the red. Yeah, you look like you know the diagnosis. Bolo. So what is your, thoughts? I'm not saying you give a diagnosis. It's a tough case. I mean.
So it can be a trauma to the neck that leads. It can be a trauma to the neck that can lead to restriction of the movement or some spasm of muscles.
No, but they are denying pain. Na? Pain would be a very important part over there.
Or
It could
So, first, where is the problem? Is it brain? Is it spinal cord? Is it brain, muscle? Is it nerve? Is it what?
brainstem.
it can be a neuromuscular junction or a muscle, neck muscles.
It can't be nerve.
It can be.
Is
No.
No, okay, fine. Somebody said brainstem.
Yes.
You said brainstem?
Could be brainstem. Could be brainstem, sir.
Why do you say that?
So it could be a evolving descending paralysis because he has a history of means some botulinum toxin like which presents as a descending paralysis. So
Botulism occurs in the brainstem?
it will usually involve the bulbar muscles first.
Get it. When I say where is the problem, I mean where is the location of the lesion. So botulism, it's a good idea, a good thought, but where is botulism? Anybody tell me where botulism is?
Neuromuscular junction.
Correct, it's a presynaptic neuromuscular junction block. What does Botox do? Botulinum toxin. You give Botox, you prevent the acetylcholine from coming into the cleft, and you get paralysis of the nerves. You get denervation of the distal axon, which is, with basically it causes paralysis by blocking the presynaptic release of exactly. So that is the neuromuscular. Where is the brainstem in it? Brainstem, you're talking about the nuclei and the long tracts and all that, which is obviously not the case over here. I mean, I suppose the only way you can justify that brainstem thing is if you say that it may be cranial nuclei. So it could be cranial nuclei, maybe the things which are supporting the neck muscles and all that. The brainstem, absolutely not. So this is a low motor neuron from the and somebody said correctly, could it be neuromuscular junction? Yes, but what are the things against neuromuscular junction?
Sir, there may be a diurnal variation or a weakness will be improving.
It would be generalized.
Where is the problem in neuromuscular?
In neuromuscular junction, the problem starts from the facial muscles.
Correct. It's ocular bulb. This is phenomenally unusual for a neuromuscular junction to have only neck muscle in movement. What about muscle disease? Somebody said muscle.
In muscle disease, the proximal muscles mostly involves and
proximal muscle of the neck alone coming acutely. What are the muscle diseases which come acutely?
Myositis.
What is the most important? Where is myositis? What is called childhood myositis or viral myositis or whatever? Where is that problem usually seen?
Legs, lower legs.
In calf muscle. Very unusual. I'm not saying it cannot be. Sometimes some immune myositis can start with neck muscle weakness. Fair enough, possible. But it's not usual. What about nerve? Is it just thoughts, sir? You think this is GBS? That is typical GBS. How? So what are the variants of GBS?
Fasciobrachial.
So myelofascia ye hai? What is myelofascia? Very good. So could it be pharyngocervicobrachial or GBS? Usually occurs after diarrhea, Campylobacter. Usually occurs in adults, unfortunately. Doesn't occur in 4-year-olds, but can occur. And there should be some involvement of this of the upper limbs or the brachial, cervical, or some problem in swallowing. But maybe we'll find something. That's a possibility. I'm not saying it is, but that's a possibility. So whenever you have a difficult case, at least
there is no history of fever, sir, and having loose motion. So non-infective can be possible too. But no fever.
I'm not a pediatrician anymore, but as far as I know, infective diarrhea.
Onset diarrhea in a child like this is always infection. That's it. Whether you call viral or bacterial doesn't matter. Which other acute onset diarrhea at this age? Okay, so it is an infection. All that I would have said is acute onset, painless, lower motor neuron lesion, localized to one area. The question is it anterior onset nerve muscle neuromuscular junction? And I think that's how it is. So acute onset, painless, inability to move. What else you want? The lower motor neuron lesion.
Since it is already, what other transient, should we think of other transient conditions or call it transient?
No, but he's still weak, he's improving.
Means we've just
you have anything in mind?
No, I'm asking like what is periodic paralysis?
No, periodic paralysis and all those kind of things, basically limbs. See, this is the location of weakness or location of involvement is very unusual. It's very unusual. It's only the neck from the history. Maybe he's got some other involvement on examination, we'll find out. So let's examine it.
It's like polio, you get only the head drops and the other things have not occurred at all.
So anterior horn cell you can get, but there's usually a lot of pain in polio. You may be right, anterior horn cell could be non-polio viruses which can sometimes look very much like. They have lag on examination. They don't come with a history that I can't move my neck. That's very unusual. No, I'm saying non-polio viruses, you may not have fever. Vaccine-induced polio or related polio, you may not have much fever. Remember that. The polio of old has gone, thank God. So all these other things, non-polio viruses and all that, I mean, there was a study I remember from Delhi where patients with non-polio had a picture of GBS with no cells in the CSF, with high protein, with no fever, with weakness which recovered, and the only way they found out was because the AFP thing came positive. So non-polio viruses, vaccine-associated paralysis, all these things can be quite atypical in that sense. Hi baby, hello. तेरा नाम क्या है? नाम बोलो. नाम बोल. नाम बोल अपना. तो एक काम कर, तू पप्पा के साथ बैठ जा. चल आ जा. एक काम करेगा? You want to examine him and then we take him there? नाम बोल अपना. तेरा नाम बोल. हाँ? उसका आवाज कम हुआ है. क्या फर्क पड़ा है? नहीं पास लो नहीं. आवाज मीन्स थोड़ा सा नाक से बोलते हैं. जोर से बोल. आमिर नाम है. आमिर. कहाँ रहता है? मुंबई में रहता है. घर में कौन कौन रहता है? मेरी अम्मी. और कौन? मेरे भाई. और कौन? मेरे को. तू लड़का है कि लड़की है? लड़का. और तेरी मम्मी? मैं तो कहाँ रहती हूँ. नहीं, तेरी मम्मी लड़का है कि लड़की है? लड़की. लड़की है. So it's absolutely normal mentally in speech. Slight nasal twang, maybe it's always been there. So उठेंगे अभी? हाँ?
Is the voice slightly weak?
Very good. बहुत अच्छा लगता है. काम करेंगे, गेम खेलेंगे. तू नीचे कर, मैं ऊपर करता हूँ. बस नीचे कर ना, नीचे कर. I can see his eye movements are full. There is no apparent ptosis. नीचे कर ना. He just drops. अभी ऊपर कर ना. नहीं होता है. अच्छा ठीक. See again he falls. नीचे कर. He's got significant neck muscle in both extension and flexion. Same time there is no pain at all. What is about his legs? What do you think of his legs? Normal? Okay. Let's see. अब एक दूसरी गेम खेलेगा. मैं हिलाने वाला हूँ. देख. एक मिनट ऐसे कर. You think his tone is normal? हाँ. क्या हुआ बच्चू? तेरे को चॉकलेट चाहिए? कौन सी चाहिए? कैडबरी चाहिए या कुछ और चाहिए? कैडबरी तो मंगाता हूँ. एक मिनट. क्या? भात खाने के? एक मिनट. Okay, show me his normal power in his limbs, or you think his abnormal power? Normal? Okay, let's see. So he's got grade 3. अरे वाह. ठीक है. हाँ. That's it. How are you? What are you testing? Which muscle?
Extensor of knee.
Extensor of knee. So what you always give the advantage to the patient. See, I'll show you. Now I'm going to test your tricep. Somebody has to hold this. Oh, let me test this fellow. She seems to be very. This fellow is strong guy. Do this. Keep it straight. Make it straight. Make it straight ना. क्या हुआ?
I can do, but it's a forceful.
हाँ. So you can't straighten it, na?
Okay.
Now I'll bend it. You keep it straight. Okay. Tight. I'm struggling. So whenever you test the power of the quadriceps, you make him do it straight and then try and flex it. एक काम कर, हीरो. तेरे को बड़ा 2 चॉकलेट मिलेगा. पकड़. ये सीधा कर. सीधा. ऊपर कर. कर ना ऊपर. जोर से. छोड़ने का नहीं. He's pretty strong. 1 minute. उठा. So when you are doing shoulder, how would you deltoid? Like this. ऊपर ही रखा. 2 चॉकलेट. जितना ऊपर ही कर. मैं नीचे करता तू ऊपर कर ऊपर. कर. ऐसे कर ना ऊपर. जोर से कर. करना. क्या कर रहा है? चल रहा है. So sometimes you cannot tell whether he is cooperating or not. Unfortunately, he's got an IV. Otherwise, you can do the wheelbarrow technique. You heard of the wheelbarrow technique? So you pick him up. Now he's got this. And you make him walk on his hands. Okay? The other thing is, let's see his gowers. He'll fall off. He won't be comfortable. What about his jerks? No, hand should be always this much movement. इतना नहीं करने का. है ना jerk? What about the ankle? Okay. Make him sit down. Bitha.
Dr. Shivani, there is a complaint about you. You are totally inaudible. So either you take a mic.
बच्चों अभी उठ. नहीं एक मिनट, तुम कुछ मत करो, तुम बिठाओ उसको. नहीं he can't. हाँ अभी छोड़ो, उठो. Little support he did take. वापस कर. जल्दी उठ. There he takes support. अभी जंप कर. नहीं अभी कूदने का. उठो उठो. इसको देखो. अभी ये जंप करो. कूदो. करो ना बच्चों. चॉकलेट 3 चॉकलेट मिलेगा अभी. चल. You can't do it. He did not get his feet off the ground. Now you can double check there, but I think he's slightly weak. Okay. Last thing you should do. एक और गेम खेलेंगे. Look for. He's got a little facial on the left. आप ऐसे करना. ऐसे कर. Tight. 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 एक काम करो, तुम पकड़ो उसको. हाथ में ले लो ना. ना कंधे पे लगा. हाँ बस. ऐसा पकड़ो. अभी एक गेम खेलते हैं. देख. Can I use your eyes? Yeah. I have to try first. इसके सामने नहीं है आज. निकल. Turn it on. देखा? अब जोर से बंद करो. जोर से. देख मेरे को खोलने देता नहीं है. अभी तू भी कर. 3 टाइम करेंगे. जोर से. 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 बंद कर. जोर से बंद कर. Sorry. When he walked, he's got lordosis. Take him out. So lordosis again means there's some weakness. See the way he's walking. ठीक है. So I think there's a mild weakness proximal along with. You made him get up.
He cannot get.
Let's see ना.
उधर जा.
He's definitely got lordosis.
I think he's so that his center of gravity falls. Otherwise, if he stands straight,
that's fine.
He's doing like that.
That's possible, but lordosis also basically means weakness of the. Yeah, so basically it's part of that. Now you may be saying maybe it's because of his neck muscle, but he's also got a little. He takes a little support to get up. He cannot jump off the ground, so I think there is some weakness. Yeah, he cannot get up from the supine position. उठो. Problem is this is too narrow. तो turn करके उठ सकता है.
उठ जा.
So he turns. He takes support again. So I think there is some weakness, but you know. ठीक है अभी लेके जाओ. Anything else you want to show? So what do you think it is now?
Sir, just one doubt. So all these maneuvers that we are doing requires his head to be supported. Can it be to avoid it because he will get a head drop?
Possible. Not denying it, but it's a little difficult when you have many things. You have lordosis, you have inability to jump, you have a little bit of support when he gets up, turning over. Now turning over, for example, you definitely need your neck muscles. But more than the neck muscles, you also need your trunk muscles. So what we can do is we can support his neck. Hold it. मैं तेरे को पकड़ता हूँ, तू अपने आप उठ, ठीक है? अभी चल, support his neck. Don't help him, huh?
Okay.
Just support his neck. Support his neck from below here, like this. हाँ. अभी तो उठ, अपने आप उठ. क्या करते? चलना, उठना. Don't help him. उठो. So truncal weakness as well. So I think in my mind there is no doubt there is not just neck muscle weakness. Now, how will you investigate him? What do you think it is after exam? So you think, let's look at the three possibilities first. You think it's GBS, atypical pharyngocervicobrachial.
It can be.
It can be good answer. So you can get jerks in GBS?
No.
Huh? No. One last thing. Sorry. गेम खेल रही पकड़ो दुखेगा तो बोलना मेरे को दुखते हैं मैं तो कुछ नहीं कर रहा हूं तेरे को देख why is he got pain so straight leg raising means what radiculopathy so it could be GBS because that's the one which comes with that. Okay? So I think GBS can come with the preserved reflexes, very well described. And usually what I found is the SLR is the most important test in GBS. Because the site of involvement primarily is the radicals. Okay? So it's possible. Chalo. मैं लेके जाओ उसको. How will you investigate? You think it's myasthenia? No facial, no ocular, no ptosis, no bulbar, highly unlikely. You think it's, what is the third thing? Muscle. Possible. No, pain, muscle disease doesn't have to have pain. If you have, for example, myositis, yes. Inflammatory muscle disease, yes. And I agree with you that the most likely think of is inflammatory myopathy, and that's why the pain, for example, in immune myositis may not be very significant. And usually inflammatory in immune myositis, what happens in childhood? It doesn't come so acutely, but what besides viral myositis, what else can occur acutely? Which type of myositis? Hey, inflammatory myopathy. Dermatomyositis. So where are the other things? Where is the Gottron papules? Where are the heliotrope? Where is the, mild contractures or difficulty in joints and stuff? So there's no skin manifestations. By the way, he looks very pale. Have you noticed that? Is there hemoglobin is low?
10.
Okay, so he's okay. Fine. Tell us, how would you investigate? कुछ तो बोलो यार. How do you investigate any neuromuscular patient? First test. First is EMG. Who said that? Nitin, I'm giving a talk. I'll just talk you back. So the first thing is CPK, no? Never do the CPK after the EMG. Why?
It will increase.
Falsely high.
Any muscle injury will increase. The CPK is always done for. What is his CPK?
That is not done.
Not done? Okay, so get it done. What else should you do?
EMG NCV.
Okay, EMG NCV. How does NCV help in acute neuromuscular disease in 2 days? What is nerve conduction and what is EMG? Before you ask for these tests, you must know what it is. So, what does conduction do?
Nerve conduction will So in the NCV, though in the acute stage, I won't do the NCV now.
No, you should do the NCV. Don't say you don't do the NCV. You should do the NCV. Yes.
But if it is normal,
but it may be normal.
If it is normal,
So
I will
with that-
repeat it after again 2 weeks.
Yeah, there are certain changes in GBS which can help you in the NCV. There are certain things which we will not talk about over here. But for example, absence of F waves, for example, absent H reflex, and all these kind of things are there which can help you to think that this is maybe a neuropathy, a demyelinating neuropathy. Then, what about EMG? Would you do EMG? What does EMG do? So neurogenic versus myogenic, correct? So what is a neurogenic? What do you mean by neurogenic?
Incremental pattern.
No. So what type of neurogenic pattern? What type? Forget the pattern itself because that's not really what you need to know. But what is a? Or you might. I'll tell you what it shows. But what is a neurogenic? What do you mean by neurogenic?
Peripheral nerve involvement, which will...
Suppose it's pure GBS demyelination. What will the EMG tell you?
EMG will not be suggestive.
Why?
So because the is the polyneuropathy, so
So?
Sir, there will be high amplitude in muscle problem, and
No. So what you have to know is that EMG in neurogenic diseases is helpful when the axon or the neuron, which is the anterior horn cell, so with a neuropathy or a neuronopathy, it will show changes usually after 2-3 weeks. Clear-cut changes. It doesn't really show changes very early and definitely not in the first 2 days and probably not in a patient with neck muscle weakness unless you do the EMG of the neck, which is a tall order in a small boy. But that's, so I think the EMG may not be really helpful. The second thing is, I grew up when polio was around. And we used to always be told, and I think it still holds true, I'm not sure it holds true for non-polio, but if there's any chance you might cause, injection worsening of the illness, it's best to avoid an EMG. So generally in this situation, we do the nerve conduction. EMG is probably going to be normal anyway, even in axonopathies and all that, because it's a very early kind of situation. The kind of changes you get, fibrillations, etc., come after 2-3 weeks. So it's a little difficult and it's not really going to help you much. So NCV, yes. EMG, probably not. Anything else? What about myasthenia? How do you tell?
Hydrophonium test.
No, you do repetitive nerve stimulation on the nerve conduction.
Decremental pattern on the EMG will be
So what you do is, you give repeated stimulations and see whether the amplitude goes down. Post-synaptic, which is usually myasthenia, decremental response. So that's something which you can do also. Somebody said what else?
So there is a question
that
if it's GBS and there is involvement of the neck muscles, should he not have some respiratory issues also?
He may, but like I said, I'm not saying it's sure. I'm saying he needs investigations. But the pharyngo-cervico-brachial component may come with respiratory muscle later. Now in his case, in 2 days he's already improving. Have you given him any medication?
No, so actually his serum potassium was 1.8.
Oh, okay. So it's a neuromuscular junction problem because of low potassium. It's extremely unusual to have this kind of neck muscle. That's the first time I've seen it. But neuromuscular junction in this case. What is potassium? Okay, so electrolytes. So what are the electrolytes abnormalities where you get weakness? Besides potassium?
So this child having loose motion, the repeated more loose motion, the loss of potassium might be causing hypokalemia also. Then.
Few days
and not very
significant.
2-3 days he had, no?
If severity is more in loose motion, the possibility the
That is possible. I'm not saying no, but was it a very severe episode?
Just 4 to 5 episodes a day.
Can.
I think hypokalemia coming after 2 days interval after diarrhea itself is not common. Second is hypokalemia coming with paralysis is a very severe hypokalemia, and there is no reason why there is only a localized paralysis. It's a generalized thing. If at all one has seen severe hypokalemia after diarrhea, well, they come flail as if they have a paraplegia.
No, but I agree with
that.
that.
We'll have to check whether this potassium is again the same, etc. Again,
have you
without giving potassium, he is improving already.
Have you rechecked it?
After some 4 hours, it was again 1.9.
Okay,
Same.
so it was definitely low in the same
Now
lab.
after correction, it is 2.4.
And he's better.
Slightly
Suppose
better.
we'll have to accept that it's the atypical form of hypokalemic paralysis. I mean, things...
What would be the pattern of recovery in hypokalemia? I thought it was usually very quick once you recover. Isn't it, in hypokalemia?
Yes, but it's still low.
Oh, it's still low.
Yeah. Okay. I remember one patient when I was a resident in neurology in Dr. Singhal's unit, and I'll just share it with you. He basically was an adult, and he came with complete quadriplegia. Morning he got up, everything was fine. He came, and within a matter of 1 hour he was quadriplegic. Did not have respiratory involvement, did not have cranial muscles. At those days when it was not so easy to get electrolytes and all that. Anyway, blood tests were sent, ECG was done. So I just put him IV inside, glucose, and I went to examine the other patient in the casualty. By the time I came back, he was sitting up and eating and all that. And then I saw the ECG, hyperkalemia. So I gave the glucose, the potassium went recovered. And then he turned out to have one of those aldosterone syndromes or something, whatever that does. So it can be very dramatic, but you must correct it. And if you're giving correction and he's still 2.4, then maybe he's losing it from somewhere else. Maybe the kidney, his renal functions.
No.
Have you done everything? Potassium in the urine and stuff like that, sodium, potassium.
What does the ECG?
ECG was normal, there were no changes of hypokalemia.
What about blood gases?
Was there alkalosis?
Yeah, because if there's alkalosis, you're thinking of Barters. That's one of the questions which has come. Have you done? Excellent.
And sir, if hypokalemia is there, there will be, in morning the patient will be absolutely normal. As the day progresses, there will be...
You're talking of hypokalemic periodic paralysis. This is acquired paralysis. Acquired hypokalemia which is causing weakness. So let's take it from another point. This is a rare kind of case. I would not take the message that the first time you see neck weakness you think of hypokalemia. But what are the other electrolytes which can cause weakness? So hypokalemia we know. Anything else?
Hypomagnesemia.
No. Hypermagnesemia and hypercalcemia. So remember, in this day when everybody is talking calcium, that's the only thing which... Remember, hypercalcemia can occur and can come with hypotonia and reflexes down and weakness. So magnesium and calcium, when they are hypo, you get irritability, and when they are hyper, you get paralysis. So I think that's an important thing. But this is I would not have diagnosed hypokalemia on the basis of this history.
Yeah. Somebody from Delhi, Dr. Pragnya, shares that they have seen such cases of hypokalemic head drop with short duration diarrhea without any other clinical manifestations of hypokalemia. And then they said when they searched on the net, it appears that head drop can be an early sign of hypokalemia. So they share.
Great. So I think we should think of this kind of situation.
What about stool culture for enteroviral related problem?
No, I think now the first thing is we chase this hypokalemia, correct it completely. If it continues, yes, we examine other things.
But this child
and
would
AFP,
be
of course, AFP, he's an AFP, no? So stool culture, you don't have to do it. You send it for AFP, no? That will be of course done. Remember, even facial palsy, if you have Bell's palsy, actually is reported, because rarely polio or NPV can even come as a facial palsy alone.
Thank you, sir.
Thank you very much for this.
I have some announcements, sir. Firstly, we would like to thank you from the bottom of our hearts for such a lovely clinic. The ones who are watching online, we are of course sir's diehard fans, would have understood why we rave so much about him. The next broadcast will be from Chennai. It will be at 2:30 p.m. on the 12th of November. And if you have missed this wonderful broadcast, please watch it online. Subsequently, the link will be uploaded. Thank you so much for coming online.